doctors and medical professionals sat together for the next years to come, so that medical science can be revolutionized. And basic fundamentals for those who are from non-medical background. And then I'll be
Sir, can
focusing
you
on
go
my
for the
part,
first
that
page
is
again?
role of
Sorry,
artificial
sir.
intelligence in endoscopy
Rakesh,
purpose.
sir, I am interrupting you. So can you go to the first page
Sure,
once
sure,
again,
sure.
because the recording has not started. The initial page. Yes, yes. Thank you, sir. Thank you. You can proceed.
Okay, sir. I'll be beginning again. This is the first one. I'm good, sir.
Yes, sir.
So,
Okay.
as I said, I'll be discussing on the overlap part of machine learning and medicine part, being a doctor myself. And it is a privilege to talk about these things because this is the future in next centuries to come. Historical context is always important as how AI come into the picture in field of medicine. And we will discussing briefly about fundamentals of AI and machine learning in medical field, in GI as well as non-GI applications. Then I will focus on endoscopic approach, image analysis, the current state and clinical evidence, its real-world applications like in polyp detection, early gastric cancer detection, in GI bleeding management. Then, most importantly, I'll be focusing on its clinical limitation aspect and challenges, and I'll be seeking help how future direction and clinical integration can be saved in following decades to come. Why AI matters in GI medicine? Historically speaking, medicine and engineering, those are two broad specialties of science, advanced science. But in 1950s, the picture where medicine and uh, engineering is trying to come together. It has many reasons. First, I'll start with a basic example. Colorectal cancer is the leading cause of death in Western part of the world. Almost third of the patient dies from the colorectal cancer. 6 lakh of patients annually are diagnosed with colorectal cancer in US alone. If I come to eastern part of world, East Asia, gastric cancer is a major concern in Japan and China, as well as in Oriental Asia. And it can be diagnosed early by early endoscopic techniques and diagnosis. But let me tell you, one of the best endoscopists can also miss almost 1/5 of the adenomas, that are the small polyps that can be a harbinger of cancer later on. Even best of the endoscopists can miss 1 out of 5 polyps in the human error part. And one context to tell, capsule endoscopy, which is available in KIMS here in some in all part of the Odisha. One capsule endoscopy can generate almost 50,000 plus images. And it is humanly impossible for a doctor to analyze all those 50,000 data. We generally go superficial to identify bleeding lesions only. So another thing is the expertise, the guidelines, the management protocol varies differently across the different part of the world. So accuracy depends heavily on the physical and physician experience. AI addresses those challenges I described in the earlier slide in these 5 parameters. One thing is it can detect in real time the pathology on the screen, that is polyp or GI bleed or any precancerous lesion. Second, it can objectively classify it. From the learned patterns, it gets intelligent on the learned patterns it got fed with, and it classify the lesions accordingly. Third, automated analysis of massive image dataset. As I said, one capsule endoscopy can generate almost 50,000 of images, and this analysis can be automated through AI. Fourth, most important is standardization diagnostic criteria. As I said, the expertise varies across the country, and that can be standardized through AI-induced algorithm. Last, the sophisticated risk stratification methods can be calculated by AI used complex algorithm models. Coming to history, this is important. As I said, 1950, Dr. Alan Turing while trying to break Nazi code, did a Turing test. That is very important to know. Turing test says that if a machine and human can talk, and human can infer that he is talking with can't infer he is talking with a machine, then the machine is considered intelligent. And that early idea of artificial intelligence started in the way back in 1950. Just 6 years after that, the term artificial intelligence came into the world by John McCarthy. In the 1971, artificial intelligence penetrated medical world by a system known as Internist One by a group of Harvard doctors, and it served basic purpose. It when it fed with clinical data, lab parameters, it can come to a diagnosis. And the next almost 15 years, there are proliferation of medical knowledge in AI. There is a system from mycin which can suggest antibiotics on bacterial sensitivity pattern, and there is DXpen also which can give you multiple differential diagnosis for a set of clinical pictures. But let me tell you, these are expert systems. Those were not known as AI back then or ML back then. Those are known as expert systems, which are knowledge-based systems. It encodes human export data. It needed a physician doctors to feed clinical data with, a lab technician to feed with lab data, and it runs through strict rules and decisions. Its strength is it is interpretable. Doctors know how it behaves, what diagnosis it could make, and it is rule-based. There is a certain rule it followed, and there is a structured reasoning, the way computer behaved back then. But this strength gave rise to limitations also, because this required extensive manual knowledge engineering that includes massive data input, and this is grossly inflexible. Means if one data is missing or there is a exception to rule, it cannot give any diagnosis. And this expert systems cannot generalize beyond its training data set. So it proved brittle and difficult to maintain. So next years to come, AI in medicine took a halt. This is known as AI winter days. In 1990s, almost for 2 decades, AI did not progress at all. But there occurs two significant historical points where AI came into the picture limelight again. One is 2003 Human Genome Project. It generated a massive amount of data set which required AI or computer assistants to encode. In 2012, there is a group of from the University of Toronto, led by Dr. Jeffrey Hinton. They won an competition, ImageNet competition. They basically developed a system which can tell any findings in the image. The cat picture of cat is there. It can assess this is cat or dog. Now, this is a new revolution, and it got applied in the medical field. In next 2 to 3 years, there is rapid development of deep learning in medical.
Rakesh sir, you can off your video so that you will get the bandwidth.
And after rapid deployment, there comes regulatory approval. And in 2017, the FDA approved the first of its kind AI use in clinical practice, that is Arteris system, which used MRI. And in 2019, AI Cancer Center AI models and penetrate. Okay, sir.
You can off your video so that you can get the bandwidth, because
Okay.
sound is not clear.
So am I audible right now?
Yes, you are audible.
Hello,
Just off
I'm
your
audible.
video. Yes, sir. Yes, sir.
Satya sir, am I audible, sir?
Yes, sir. You are audible. You are audible, sir.
Yes, sir.
Just off your video so that the sound will be clear. I think, sir. Yes, sir, you can continue. Rakesh sir, share the screen again. Some network issues are there, I think. Yes, Rakesh sir. Yes, it's coming, sir. Yeah. Yes, sir. Share the screen. Yes, yes, it's coming. Can continue, sir.
Am I audible now? No?
Yes, 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 sir.
Sorry for the delay. I think
No,
there
no,
is
no, no problem.
So in 2015-24, the regulatory approval timeline came into the picture because rapid proliferation of AI in the medicine. In 2017, artery system was approved by FDA for clinical use. In 2019, almost 2 years after that, the first cancer diagnosis was approved. And it penetrated so much into the medicine field that as of 2023, almost 692 ml based medical devices were came into picture. But this explosive growth promise validated later on. Coming to this algorithm uh,
Definitely, the network issues are is not able to. Yes, sir, it's coming. Yes, sir.
okay, I'll continue.
Some network issue is there. Yeah.
So traditional machine learning algorithm that has been used in gastromedicine. First is gradient boosting model. This is a ensemble method. Keeps on data from the tabular method, tabular clinical data, and makes prediction tree. And sequentially, it makes better prediction score after multiple and sequential tabular data formation. And it usually used in GI prediction risk. Another one is random forest. It rather than it sequentially, it simultaneously causes different kind of uh, algorithm data and choose the best among it. It is robust to outlier data mainly, and it it is good for feature importance. It is used mainly for risk stratification for GI bleed and polyps. Then another, there is support vector machine. These are generally used for binary competitive data, and it is useful for GI cancer detection. Then comes this, the most important part. This is called deep learning convolution neural network style, which has been in use for mainly image analysis from endoscopes and colonoscopes. There are multiple layers in it. There are early layers, middle layers, and deep layers. Early layers generally identify the edges, colors, and basic texture of the image, and middle layers add shape to it. That is what is the morphology and tissue characteristic. And the last is deep layers, which gives output to us, which can use semantic concepts like human things, and it can give a picture whether this is a polyp or a cancer or bleeding stigmata. The various keys in architecture used in GI application. I took this table from a recent review article. Uh, I'm not very well versed with it as a medical profession. I think I'll go through the basics. I'm sure the learned audience here can grasp more than me. There are only 5 to 7 kind of CN architecture has been in use for GI application. First is ResNet, that use skip connection, and it is mainly used in polyp detection and gastric cancer classification. It has shown high accuracy rate, the 90 to 95%. It basically do 100 to 150 type of analysis, and after that it comes to this kind of accuracy. Uh, Compared to that, there is a YOLO, that is you only look once. That is a single stage detector. It balances speed with accuracy. The ResNet, when goes to 100 and 150 cycles, it is a tad bit slow, but YOLO is a faster kind of AI. And it has shown a list accuracy, that is 83.6% accuracy on colon polyp detection rate. If I come to swing transformer, this is an advanced version of YOLO, that is YOLO version 5. It basically improves the accuracy rate by more than 5%. And it improves the polyp detection along with more accuracy and a faster AI than YOLO. And then there is mask RCNN. It basically do the instance segmentation. Whatever I read and understood it, that is, it divide the data, segregate the data into different parts, simultaneously analyze it, and gives us a picture. Output in the output picture gives us a conclusion on it. It is a powerful tool. It generally utilized for early gastric cancer detection and polyp segmentation with a high accuracy. That is almost 95.12% accuracy on a special kind of imaging that we say NBI, that is narrow bandwidth imaging. And then there is another 3D CNN. Three-dimensional CNN gives the advantage of real-time video analysis also, and considered superior to 2D methods. And while we describe in different studies, this AI is better performing than this machine learning models. We generally use this kind of parameters, like what is the sensitivity there, what percentage, in what percentage case they actually able to identify the polyps that is there. The target must be more than 90%. Specificity is the just opposite, but is very important, that it cannot detect the lesion where it is not present. That is called true negative. There's some earlier kind of AI can detect a water bubble also as a polyp. That is false positive. But if it can say that it is not polyp, then that is called the true negative, and it signifies the specificity, and its target must be more than 85%. Then there is the detection parameters like OROC, area under curve. There is a curve, and the area is calculated. 0.5 is random guess, 1 is perfect diagnosis. We in AI target more than 0.9. Then there is adenoma detection rate. We as a endoscopist try to achieve humanly the 6%, and with each 1% increase in adenoma detection rate, the colorectal carcinoma risk is reduced by 3 to 6%. That is, if we use AI and we can enhance our adenoma detection rate by almost 5%, then one third of the patient in which the colorectal carcinoma can happen in future can be prevented. That is the importance of this. Coming to evolution of AI in GI endoscopy per se, there are phase-wise development. The first phase was computer-aided detection, CAD-E. It started momentum in early 2000, in the first decades of the millennium. And it could able to identify early lesions only. Only they can flag suspicious lesion to be evaluated thoroughly by an endoscopist. And it basically supplemented the efforts of endoscopist per se. Then came the 2010 onwards, that is computer-aided diagnosis. It can detect and also can classify the lesions, that is benign versus malignant, or bleeding risk versus non-bleeding risk, characterize pathology. And it can help the doctor to decide whether to resect and discard or whether to monitor the patient with repeat endoscopy. Then comes the current concept, that is integrated. This is integrated of CAD-E and CAD-X and a different multimodal approach. It gives us a real-time complete analysis. It is basically ensemble models we're talking about. Then the use of AI in clinical practice. There are multiple uses, but I will be discussing on three key areas where AI has significantly contributed to GI endoscopist. First is polyp detection. Second is GI bleed. And third is IBD and H. pylori detection. The polyp detection is very important because almost, as I said in the first slide, even experienced endoscopist can miss almost 1/4 of the adenomatous polyps that can be harbinger of full-blown cancer in the stage. And then AI can achieve this sensitivity up to 88% in initial CAD model. This is in 2015, Tajbox et al. First did this study on CAD model and could achieve almost 80% sensitivity for identify those polypoid lesions. And this is very important because those are important for polyps of less than 5 mm, diminutive polyp size, which can be easily missed in the human eyes. This is the key polyp detection study. This is by Jonathan Mucker et al., published in 2025. And this systematic review showed adenoma detection improvement is almost in 7 to 10% absolute, which is beyond our human capability. And real-time performance has improved to 30 to 50 frames per second, maintaining detection accuracy. Miss rate, the adenoma detection miss rate has been reduced to almost half, that is 40 to 50%. And there is multitasking capability, like it can simultaneously detect, can localize and classify the polyp. The newer kind of systems has seamless integration with the endoscopy suite workflow. Then there is a RCT by GOB et al. In 2020 published. This is a graph. This is the RCT, prospective RCT, almost 863 data set. And is important to focus on the first part, the diminutive polyp that is less than 6 mm, which is almost impossible for the human eye to catch. The AI have achieved almost 93.3% chances to detect it. And it is significantly, it shows significant difference with the human eye. The blue part is AI, the gray part is control part, and the CAD-E part has shown significant improvement when polyp size is less than 6 mm. Then there are some FDA-approved polyp detection system. First is EndoBrain, which is approved in Japan in Olympus endoscopy group that has been in use since decades. It has achieved almost 90% of true polyp detection and 93% of true negative detection, that is specificity. There are few in the market like endoscreener, EndoAid, but most studies are done on EndoBrain techniques. There are multiple regional systems are also approved in the district level or state level wise in Europe and Asia. Then there is the second one, early gastric cancer detection challenge. As I said, colorectal cancer is prevalent in western part. Early gastric cancer is prevalent in eastern part of the world, that is Japan, few part of India and Oriental Asia. These are very subtle lesions. You can see this in image. You can't detect this is cancerous. Even expert endoscopists detect only 60 to 70%. One third of the small polyps are missed in endoscopist eye. And most importantly, these are non-specific symptoms. Patient comes in the OPD for the dyspepsia symptom, acid-related symptom. And when they present to us with a mass, it is in advanced stage. So AI used in early gastric cancer is the need of the moment. The first evidence in 2021 by Economy et al. They showed this is a black dot is the CADI related diagnosis, and these are the endoscopist method of diagnosis. It is a last data set, almost 13,000 of endoscopic images, both conventional endoscopy and narrowband imaging. Result is staggering. Almost sensitivity is 58.4%. The normal endoscopic image sensitivity was almost 40%. And CNN shows significantly sensitive as compared to endoscopist. And there are multiple system also. Just to let you know, the YOLO architecture used in 2021 study, which achieved accuracy of 85%. There is mass RCNN, which achieved almost 95% sensitivity on NBA. And there are multimodal approach like endo-angel system, which are been in study since 2022 across 2024. There are multiple endo-angel system like endo-angel MM, endo-angel LE. There are multimodal system. And the first one was published in Gastrointestinal Endoscopy in 2022, and it can achieve more than 90% sensitivity. Current impact in AI in early gastric acid detection, it classify endoscopic guided biopsy targeting, it can reduce diagnostic delay, it can standardize criteria among different countries per se, and this can be used as a training tool. Third most important, AI for the GI bleeding detection. The first part I said, one capsule endoscopy can generate more than 50,000 plus images, and upper GI and lower GI bleed can have almost 10% in hospital mortality. So problem is the traditional clinical risk like Glasgow, Blatchford, Rockwell, or M65 provide a basic prognostication, and it has its own limitation. AI has outperformed the traditional clinical risk scores. The AI has reached almost 96% sensitivity in detecting early GI bleed, in prognosticating the GI bleed, which patient need hospitalization, which patient needs PRBC transfusion. The traditional scores are static, may miss complete interaction, and has limited predictive discrimination. The machine learning, like gradient boosting model, has outperformed in classical approaches. There is a landmark study by Song Dale et al. In 2022, which showed, and in subsequent studies also, they have achieved area under curve more than 90 with gradient boosting model. It has validated externally also. There is a paper now accepted in World Journal of Artificial Intelligence by me and Dr. Panigrahi. There is a review article, and these are the studies in acute upper GI bleed. And these studies outrightly said that AI outperform the conventional risk scores, especially for endoscopic therapy. And there are multiple evidences on it. Mostly they are retrospective, but there are few prospective data which support. Currently, AI in GI bleeding is used for risk stratification and other presentation itself. When patient comes to our OPD or our emergency ward, it can real-time detect which patient should be admitted, which patient should be given PRBC transfusion. And it can predict which patient can be early discharged. And there is individualized intervention timing, which patient needs endoscopy in which period of time. And then comes AI beyond the acute diagnostics, that is IBD monitoring. IBD is a inflammatory bowel disease, is a chronic inflammatory condition of gut where there is bleeding, diarrhea, weight loss, and stricture formation. AI is a very difficult pathology to pick for endoscopist also, for pathologist also. AI help in diagnosis making, in endoscopic remission status, as well as real-time quantification of mucosal inflammation. That is the job of pathology actually. And there are few papers and few from the India has come up that AI has assisted in diagnosis for gastric H. pylori. You usually do a biopsy study to know it, but now AI engines have performance of almost 86% and specificity of 87% for mucosal H. pylori pattern just by looking at it. And clinical benefit that it enables immediate diagnosis without biopsy delay. We don't need to do biopsy for it. What are the frontiers? There are a few vision transform, like swing transform I talked about. It is a improvement version of YOLO version 5, and it can increase the accuracy by 5.3%. It captures long range dependency, and it is a bit better than pure convolutional neural networks. 3D CNN, as I said, it can process video analysis in the real time. Most important, the emerging frontiers is AI in few Western countries has a seamless integration with electronic health records. The patient health record go hand in hand with the AI system, and they can predict this patient is going to have polyps or this patient is going to have GI bleed in the future. Then there are one paper I found yesterday for robotic assisted endoscopy. They are very early to say that, but they are in the market. They are wearable also. You can wear a spec while doing endoscopy, and these lenses can monitor the screen, and they can say this is polyp or not. There comes the multimodal AI. Multimodal AI means there is an integration of endoscopic image with the genomic data or serological markers or clinical history of the patients. It enhances accuracy through multi-source channeling. It can give personalized progression. That means one rule doesn't fit for all the patient. If you come to my OPD and your friend comes, management may be different, and AI helps in this. And there are, as I said, there are multiple system device for that. One is EndoAngel MM, which demonstrated this multimodal imaging, white lace as well as narrowband imaging. Another thing is explainable AI. AI is a black box. What goes inside, what comes inside, we physicians don't know. I'm sure you engineer guy, engineer people must be aware that whatever the process is going on in between. But we physicians don't believe what we don't know. We study thoroughly and then we give opinion, we give suggestions. But this AI is a mystery to us. We feed data and gives output. Whatever is going inside, we don't know. So we term it as black box. So there is an inherent clinician hesitancy. Solution: maps, attention maps, saliency map, and the important feature in tabular format or interpretable model architecture, which we can understand. There are few systems in place, EndoAngel LA, which have improved human computer interaction, and it is essential for at least for our doctors. Then the most important part, the limitation. The study I quoted that AI has outperformed all the endoscopists in almost all of the study, but those studies were retrospective. Most of the AI models were trained on the retrospective data or single center data. The patient population is unrepresentative. There are Japanese people, there are American people. In Indians needs our data system. There is equipment bias also. So practical impact is almost 90%, 5% accuracy in tertiary center. But in community hospital, where Odisha lags behind, is the accuracy dips down. Then there is generalization and validation challenges. FDA in one of the study found that 71% of approved AI used is for retrospective evaluation only. We can't always apply it on prospective basis. And 72% did not report multi-site testing. Only single center site is present. So almost all of the data I discussed here cannot be generalized in India and Odisha person. Then comes the black box problem. The clinician has inherent resistance to following the unexplainable recommendations. And there is a agencies increasingly demanding explainability. There is liability concern, and there is increased need of explainable AI for the pictures. There is regulatory issue also. Our Indian government or NMC has not devised a complete AI model specific plan of action as of now, and you are still in horizon in the evening also. And there is a practical problem of reimbursement if patient has come through any insurance policy because of no clear-cut framework policy. Skepticism is rampant among clinicians. If you ask me about my opinion about AI use in my clinical practice, I'll be hesitant because I don't know yet what is the future, what future holds for us. There is concern of the liability. Patient may sue us if anything goes wrong. Fear of job displacement. If AI do the polyp detection, what is my job? And this is almost palpable in the radiologist's mind. AIMS New Delhi approved AI use in X-ray imaging. X-ray imaging, of course, with the radiologist supervision, but this kind of anxiety is palpable in the radiologist's mind. One most important thing is AI needs a large data set. The convolutional neural network needs large and repeated data set to evolve itself. So the patient with rare disease in which our medical fraternity has less data on, the AI falters. It is excellent for common condition, but less reliable for the rare entities. So solution you people may give us, but I think data augmentation solution partially successful, but this is imperfect. Predictive analysis, moving from what is this to what happens next. We are now sure this is polyp, this is GI bleed, but what is next? What AI can do? What AI more can achieve? Can AI detect polyp recurrence rate? Can AI risk stratify cancer with genomic integration? And it can predict IBD in the family tree. And there is another thing is privacy. We generally, while doing medical studies, we don't share data without patient permission. We take thorough consent of the patient. But these training models needs data input, constant data inputs. It aggregates training across diverse population. So their privacy is a concern. Future, the adaptive AI learning with continuous learning. That is AI system improves through exposure to new cases. And the predetermined change control plan is emerging for the new horizon. There should be defined protocols for model updates and validation. The post-market surveillance is the key. Critical priority is the health equity in AI practices. The training data is skewed towards specific demographics. This is important. As I said earlier, Indian data is not represented in AI recently. There is underrepresentation of women, the underrepresentation of minority and elderly population. The path forward is delivered effort for diverse training data set, and we can contribute in our level. So what is the path forward? There should be rigorous prospective multi-center validation replacing retrospective studies first. And secondly, there should be explicit attention to health equity and diverse population. There should be clear regulatory frameworks enabling innovation safety. Clinician education is paramount. That's why thank on the starting of my lecture to Professor Satya sir that for we clinicians are getting educated, but getting AI as a collaborative intelligence, not as a competitor. There should be transparency. There should be post-market surveillance, building trust. Future is collaborative. AI augments human expertise, not replace it. Human judgment plus machine learning is better patient outcome. This is not competitive. The question is not will AI work, but it should be how will you deploy it equitably and responsibly. Thank you. Thank you for that answer.
Thank you, Dr. Rakesh. So due to shortage of time, we can take only one question, one or two questions. All other students can just mail me. I'll contact Usha to give the answer of a question. So I will ask Dr. Punapa, who is a assistant surgeon. from Mysore. He is currently pursuing his MCA in AI and data science due to a lot of interest towards the AI. And Punaba just asked one question, then we'll start. Dr. Santosh Das is waiting. We'll do that one. And definitely, Dr. Rakesh, I will contact you to do some more collaborative work.
Sure.
Good afternoon, sir. Thank you, Dr. Rakesh. It was a brilliant presentation. But you have already told all the negative aspects also, because the standardization is an issue, generalization is because we do Olympus, Fuji, and Carl stores. They have their own settings and their image capturing. So how do we generalize these things? That will be an and labeling the data also. I may say it's a polyp, but you might not agree with that. So again, it will be incorrect data. I think the American Gastrointestinal Surgeons Association have sort of skeptical about the polyp detection. AI primarily enhances the detection of smaller polyps, but rather than advanced adenomas as polyps, because it is unable to distinguish. And the adenoma is more important for cancer rather than just a polyp. So I think still, as you said, we have a long way to go, and the black box is there. But overall, we have initiated, I think, Satya sir has initiated this collaboration between medicine and computer science. Let's see how things go. Thank you very much.
Very important points, sir. Very important points.
Thank
And
you.
this is what I tried to explain, that this is not perfect. AI in medicine is not yet perfect. Collaborative work is needed. They take training data set from us. We control it for the next century, I guess, so that our job is safe.
Yeah.
Thank you. Thank you, sir, Rakesh sir, for coming here with a short notice. So definitely I'll be in contact with you and I'll contact with the students and participants. Whoever questions are there, I'll take with you. Thank you, sir. So now we have the next session and Dr. Santosh Das. He is going to present the next session on real-time NBC, I think nerve conduction velocity, interpretation using the machine learning. So let me introduce Dr. Santosh Kumar Das. Welcome, sir. Dr. Santosh Kumar Das, MBBS, he is a gold medalist, MD in internal medicine, DM in neurology, is a leading neurologist and professor, and who is heading the neurology department of KIMS, Bhubaneswar. He provides evidence-based diagnosis and treatment for a wide range of neurological conditions, including epilepsy, stroke, movement disorder, headaches, neuroimmunological disorder, pediatric neurology. He has over a decade of clinical experience and is recognized for his academic excellence and patient-centered care. Actually, Dr. Das completed his MD in internal medicine from BD Sharma PG IMS Rohtak and his DM from Nimans, Bangalore, where he was awarded the best neurologist resident. He has published numerous research articles and international peer-reviewed journals on topics such as neuroimaging and movement disorder, strokes. He is also active member of major neurological association in India. And Dr. Das is very much active in social media, we can say. So wherever he is experiencing the new cases are there, so definitely he wants to tell about that particular disease so that others can aware about that one. So thank you very much, sir. Now I'll hand over the session to Dr. Santosh. Now, sir, you can session is yours. You can continue. Thank you, sir.
Thank you, Satya sir, for a nice introduction. And at the outset, I am thankful, sir, for giving me the opportunity to speak on this topic. Sir, is it visible, sir?
Yes, sir, visible.
Sir, actually, it is very focused topic. It is not like AI in neurology or neurodiagnostic. Recently, I am just searching because in our clinical practice, like in peripheral practice, I am going and seeing 100 patients per day and around 20 patients are undergoing nerve conduction study. which is a very important test for diagnosis of peripheral neuropathy. As you know, in our world, in Asian countries, diabetes is very rampant, and diabetes having lot of complication, and among complication, neuropathy is a major complication. So when we were doing nerve conduction study, what we are finding the difficulties, we are not able to give the report in a short span of time. So because there are many data are there, and we have to analyze the data to get the result. So in what way we can use the artificial intelligence and machine learning approaches so that the exactly we can give real time NCS, that is nerve conduction study data, to the patient. So I'll just briefly tell you, you can see this is our human body, and there are peripheral nerves and central nervous system. So we have a brain and a spinal cord, and lot of these yellow are peripheral nerves which are coming from the spinal cord. So there are numerous nerves. The main aim of the nerves are to control the movement. Like I am doing some activity, I am holding something, it is by the nerve. Also the sensory part, by which I am feeling something, like I am touching a cold water, I am touching a hot cup of tea, and I am feeling the hot sensation, cold sensation. That is the sensory part, and other part is the motor part. So the core concept that we have a test that is known as nerve conduction study, or NCS test. It is a standard neurodiagnostic tool to measure how fast the electrical signals travel through a nerve to detect a nerve damage or dysfunction. And we have a machine learning approaches, which is a type of artificial intelligence which use large complex biomedical data and identify subtle patterns that helps clinician like us to quickly give the result, or sometimes if we miss something, that can helps us to identify some problem. So here we want a real-time interpretation of these machine learning algorithms to process the raw nerve conduction data, that is signals, quickly, and to provide immediate automated result to us, so that we can start treatment quickly, and patient also can learn what disease he is suffering. So that is the core concept. So we have a patient, we have a nerve conduction test, which is a documented test routinely we are using, but the issue is that it is a long lengthy test, around 45 minutes for a patient, and there are a lot of data is there in that graph. We have to analyze, and how quickly we can analyze by using the machine learning approach, so that we can give a real time result to the patient, which helps us to start treatment early. So the background, it is a study which helps in our peripheral nerve diagnostic. Mostly nowadays we are using the manual interpretation, which is time consuming and requires expertise, needs for standard, rapid and accurate evaluation, which is not there now. So as I already told, we are seeing lot of patients, so increasing patient load. So we need a automated software or machine so that it can give result immediately. I will give one example. Before 10 years, what like complete blood count, it is a blood analysis where manually you have to analyze the what is the hemoglobin, what is the WBC, what is the platelet. But now we have a machine, within short span of time it is giving automated result of complete blood count, and nowadays nobody is doing manual CBC analysis. So the machine or technology advanced so rapidly in a span of 5 to 7 years. So we need that thing in our nerve conduction or electromyography, that is a test for muscle disorder, or test like epilepsy diagnosis where we used signals from the brain, that is the EEG. So how quickly we can give the result. So what is a NCS? It is a diagnostic test. Purpose is to assess the motor and sensory nerve function, to detect if any nerve damage is there, either there is a delay in the electrical transmission conduction, or there is a some block. So this is a machine which is there in every hospital where neurologists practice. So, and this is the test. So what happened? We have to put some electrodes where there is a cathode, there is a anode. We have to stimulate the nerve, and we have to record in the machine. And how it will see? So the graph will look like this. So this one, it will be the normal thing, and the data will look like this. Just imagine the data. So there are so many things in the data. You can see we have in the nerve, we have a latency, we have a amplitude, we have a velocity, and which nerves we are stimulating. And there are motor part, there are sensory part. So we have to analyze all the data from that particular test. It is a one patient test, and it is only 50%. It is not complete nerve conduction. Complete nerve conduction may another 2-3 slides it may required to put all the results. So I just keep on the major part. One is motor and sensory. You can see lot of data, numerical figures are there. We have to analyze and we have to give a report. And this way the graph will look like. So what is there in the major thing? Whenever you are stimulating a nerve, you will get a graph like this. So the first part is the latency on what's after how much time the amplitude is coming. So this part is the amplitude, this is the latency, and this is the duration. So whenever you are stimulating a nerve, you have to get the latency, that in the millisecond, how much amplitude you are getting in the after stimulation, that is the amplitude in millivolt, and one is the conduction velocity. You have to stimulate distally and proximally so that you can get a conduction velocity. So you have to stimulate a nerve, you have to record from the muscle which supply that particular muscle, and you have to get the result. So this is the complex scenario we are facing in our every day-to-day practice in our VG OPD. So we want the machine learning and artificial intelligence use, how smoothly the machine can analyze all the data and give the result. So what are the evidence, how the Western literature is there, means how they are using this concept, and how we can do in our practice in Bhubaneswar or in India. So there are multiple data, as I already told. We have an amplitude, we have a velocity, we have a latency. From these three things, we have to tell the patient, okay, you have a nerve damage, and from this data, we have to tell whether it is a axonal damage or a demyelination damage, whether any block is there. We have to give the result. So this is the classification of the nerve damage. These are the data. Based on the data change in the NCB values, we will manually tell the patient that these are the abnormality, and you may suffering from axonal neuropathy or a demyelinating neuropathy, or it is a immune mediated neuropathy. So what we are doing nowadays. So why machine learning for the NCB or nerve conduction study interpretation? So traditionally what we are doing now, it is a operator dependent. Those technician who is doing the nerve conduction study, he will bring the result, we will analyze the data, we will tell him, he will go type and he will give to the patient. So it is actually it is a time consuming process, and there is a subject of inter-observer variability. Like sometimes you may say tell that no, this amplitude, because there is a range, it is not a fix. Like a median nerve conduction, conduction velocity or latency is it should be 2 to 4.5. So somebody, it may be 5. So somebody may tell no, it is slightly prolonged. You may tell that it is much more prolonged. So there is a inter-observer variability. So what machine learning helps us, it will give real-time pattern recognition of the problem. It will objectively classify the problem, whether it is axonal or a demyelinating or a mixed damage. It is automated quality control the data, and it helps us to give the result quickly, also helps the patient to get the treatment early. So that is our aim, how we can smoothly give the result. So what will be the role of AI in neurodiagnostically, specifically neurophysiology like nerve conduction, EMG and EEG? It will analyze large and complex data sets, many numericals it has to analyze. It has to detect hidden patterns and anomalies. So there will be reduced observer variability, provide consistent and reproducible interpretation, improve diagnostic accuracy, and most importantly, earlier, less time and precise diagnosis possible by use of AI and machine learning. So what NCB data is used for the machine learning models? As I already told, we have a raw signal. I already showed the graph. We have a raw signal. So we have amplitude, we have latency, we have duration, and from that we have other parameters like age of the patient, height, limb length, temperature, which nerve you are stimulating, distance of the stimulation. So these are the input data which the model has to pick up before analyzing all the patient data. So this is there in our nerve conduction study, which is required for the machine learning. So the workflow will be like a signal acquisition of the raw data. There will be automated processing or pre-processing like the filtration, artifact rejection, baseline correction. It has to use the CNN model, as the previous speaker already told. So it will give instant classification whether it is a which type of nerve damage is there, and that result to be clinically validated by some clinician and will give immediately to the result. So that should be our plan or workflow, how the machine learning model will help us in analyzing the raw NCB data. So the CNN model already described from the previous speaker, it will require EMG and NCB waveforms, automatically extract features, and the model output a prediction in real time, whether it is a normal or abnormal, whether it is axonal or a demyelinating, whether any blocks are there or any abnormality is there. So this will be our result. So it will signal acquisition and pre-processing. So first step, it will filter all the noise and it will analyze all the latency, amplitude, temperature correction, automated feature extraction, all the major parameters it has to extract, intelligent interpretation and classification of the pattern recognition, which nerve, which type of neuropathy, whether axonal or demyelinating, and it will give the report real-time basis by the analysis. So what will be the benefit? If you see the traditional manual reporting, which is now ongoing worldwide, and AI-based reporting. So manual reporting only 15 minutes, test 30 minutes, so around 45 minutes. But AI reporting after the test, hardly 1 minute, it will give you report. Consistently, highly consistent AI-based reporting, and it will handle all these artifact, noise, and other things so that it will give the immediate result. So very significant amount in the time to give the real-time report rather than the traditional manual reporting. So there are very few studies. It is not very well studied topic, especially in the clinical neurophysiology. There are hardly 4 or 5 studies in the NCB. This study I am quoting, it is published in September only, 2 months back. It is a agent guide AI power interpretation and reporting of nerve conduction studies and EMG, that is the INSPIRE model. And what they have done, so they have done a model which is basically different from the base LLM model, that is a large language model, and they have used agent guided AI power interpretation and reporting, and by that they have found that its accuracy is around 92% in detecting normal versus abnormal tests. So this is most important. The patient wants to know whether my test is normal or abnormal, and by this model they proven that around 92% it is correctly telling whether it is a normal and abnormal. But it is a multimodal AI model. That means there are 2-3 models. One model will take the analyze the history part, what is the history or chief complaint. Other model analyze the test value, and other part will give the result. So by this multimodal AI thing, they are giving the result which is very accuracy. So as I already told, it is a multi-agent AI model where clinical data is required. What is the patient complaint? Like patient will complain, I am having a tingling sensation, I am having a numbness in the feet or the hand. Then by that, there will be analysis about the whatever the result we are getting from the test. There will be report drafting and by the validation. So this model they have used, and they have proven that it is close to 92% accuracy in telling whether it is a normal or abnormal, also in pattern recognition of what type of neuropathy the patient is suffering. So we have a traditional model and we have the new INSPIRE multi-agent model. So there you can see the traditional model accuracy is around 60%, and in the here the accuracy is more than 90%. So what is the major difference is that in the traditional model, you can see often ignores the clinical context, focus strictly on numerical NCS and EMG values. So that is the most important thing. Like patient history is very, very important in analyzing a report. It is just not that you will give some numerical figure and there you can draw the result. So for anything, for MRI, for EG, you have to you have to know the history. If you don't know, okay, the patient having a tingling sensation in the upper limb, or there is no symptom in the lower limb, but the data is telling that there is some symptom in the lower limb. So sometimes you have to ignore some many things if the patient don't have the complaint or you don't find any problem in the patient. So in the multimodal model, they have taken the patient history and doctor's examination finding, which is there, which was missing in the traditional model. That's why the accuracy is very, very high. And second thing is that they have used the established reference tables and guidelines. So in the multimodal model, like they have American Academy of Neurology, neurophysiology parameters, where they have a strict guideline. So in this multimodal model, they have used that reference table and guideline values in giving the result. So they will take the history, they will analyze the log values, they will compare with the established guideline, then they will confirm with the physician, and they are giving the result. That's why this multimodal model having accuracy of more than 92%. This is known as INSPIRE multi-agent model for real-time analysis of nerve conduction study. To confirm that INSPIRE model is working or not, they have given a scoring system where this is known as IGERS, that is AI generated EMG report score. Like they have few points like whether the signal quality score is better or not. So they have a score from 0 to 20, whether patient score is 0, 10 or 15 or 20, whether the features extraction accuracy FEA, there is a scale, whether the pattern recognition confidence, there is also another scale, whether the clinical concordance score is there or not, whether there is ERC, that is explainability and report completeness, is there is some scale there. So this IGERS, you can see it is a standardized quality confidence and concordance score for a AI assisted EMG NCS reporting. So it is a composite scoring system. So what you'll see, so the total score will be the 8. So if the report is coming like score of 90 to 100, that means it is a highly confidence, highly accurate, and it is a report ready. So you can give the report to the patient. If the score is less than 60, so that means there is defect in that test or the defect in the result. So you have to analyze manually or you can run that test again. So they after the result, you use the score to tell whether this test gave the report correctly by using the IGER score, that is known as AI generated EMG report score. So they have done, that group also done a AI based image reporting, that is AI a randomized control trial. So they have used this INSPIRE model. You can see I already shown the figure. We have a nerve conduction study. These are the graph and these are the database. So what they have done in this randomized control trials, so there are 3 arms are there. One is AI along with physician, one is exclusively physician, and other is exclusively AI. So after that they have compared, one is interventional report, one is control, and one is AI draft report. So they have used, and they found that this model, this RCT model is, that result I already showed, it is more than 90% accuracy in getting the result as compared to the physician alone. So this much of literature is currently available in real-time analysis of nerve conduction studies by using INSPIRE model and IGER score. So what they are thinking, if this thing, because lot of things are still going on, if it is still going on, so what will be the future? So future will be the real-time procedural guidance. Like future AI will provide, like I am doing a test and I saw a waveform, like what we are doing. I am sitting in my OPD, my technician is doing the test and he finished the test. He brought the result and I saw the data, then I will give the result. But there is not any real-time feedback is there. It is not there. Whether he has done the test correctly, whether the waveforms are suboptimal, whether the current required more. So the real-time procedural guidance the AI will give if it will integrate in the nerve conduction machine. As I already told, it required a multimodal integration. Like we are doing a nerve conduction, we have a neuromuscular ultrasound. So we have to take the picture of that nerve. We check the area of the nerve. So it will integrate the nerve conduction and ultrasound image to more clarity on the nerve health. Another thing, it will help in the predictive phenotyping. Like we have a nerve damage patient. So by this predictive model, we can tell, okay, you will improve or you will not improve, or it will take 1 year to improve. So like this, we have predictive phenotyping so that we can prognosticate the patient by analyzing the data. So other things are there, but these three things are very much important. Major limitation, as my previous speaker already told, so there is a bias or a tap in the automation. Like what is automation? Like we have a many nerves, median nerve, radial nerve, ulnar nerve, upper limb nerve, lower limb nerve. So we want a automation. That means our machine should correctly identify, okay, this waveform is from which part of the nerve. Other this thing is correct or not. So automation is very much required. We have a technical and data challenges. As already told, there is a ethical risk whether this report we are giving to the patient is accurate, whether these things to be again validated or cross verified by a physician before giving to the patient. So what we are thinking, whether this can be a funded project, that is a real-time machine learning based pattern recognition in nerve conduction study, a prospective validation study. As I already told, one trial previously published, whether whatever the machine learning is giving as compared to clinician report, whether we can validate the machine learning approach and give accurately, whether it is a accuracy versus expert interpretation, time saved for the study from the old to the ML model, that is machine learning model, and the inter-observer agreement, whether this type of thing can be a future project so that we can use this in our day-to-day practice of nerve conduction analysis. So the final perspective is the goal is augmented intelligence, not the artificial intelligence. The most successful clinical environments will be those that treat the Inspire model, that is the multimodal AI model, as a highly skilled digital resident. Like in our Niman stage, we as a resident, we use give the report to our faculty. So we want the machine learning to be used as a digital resident capable of doing the heavy lifting, but requiring the seasoned oversight of a human expert. As our resident is doing, like they are giving the report and they are bringing us the reports, or this is the report, and we will verify, okay, this is the correct report. So you want the AI, our digital resident, so that it by our oversight, by our expertise, we can give the report so that the patient can get maximum benefit. We can help the patient by giving real-time analysis of their report. So these are the reference few studies, as I already told. This paper, he only published these two paper, one in Journal of Neurology, one in Journal of Clinical Neurophysiology, Gonstein, and very less papers are there. So this is our aim, means which on what stage we are now existing and in what way machine learning can help, so that it helps our clinical practice and to help the patient. Thank you very much.
Thank you, sir. Very informative, and I think definitely whatever things you have suggested, we'll try to do that one. And now it's open to question answering session. Yes, Yathat, you can take the first question from you. Yes. Unmute yourself, Yathat.
Hello. Okay.
Yes.
So hello, sir. It was a really great presentation. The question I had was that the machine which is utilized to actually extract the signals and the information in the first place, what uh, of which of those parameters are more prone to noise? Because recently I was working on a project and there were certain parameters that were more noise prone, so I had to process them differently and had to uh, like add extra layers to the pipeline to make sure they are not interfering with the final results and the final analysis. So which of these parameters are more noise prone, and how are they currently handled, and how do you think they can be handled better? Thank you.
Sir. I
So
think
this is for me now.
yes, sir. Question for you. Which are the
Actually, yes,
very
yes.
much
I
important?
heard the question, sir. Actually, in nerve conduction, as I already told, it is a electrical stimulation. So to in every lab, neurophysiology lab, we have a big earthing is required, and we have a wooden table so that the current and earthing problem should not be there, because if it is there, we get lot of noise during the graphs. As I already shown in this graph, it is very clear because there is no noise. So what we are doing, we are using the filter. So in our machine, we have filter. We can use high filter, low filter, like settings are there. Depending on the noise, we can use the filter so that we can exclude all the artifacts or whatever noise artifacts or electrical artifacts or sound artifacts. Anything is there, we can exclude. So in that study, sensory studies, you can see we have a motor studies, we have a sensory studies, and sensory studies are very prone for this noise artifact. So to get a correct graph like this, it is a very clear graph. So to get a graph like this, we should have, means our artifact should be very less. So first answer, in the motor and sensory is very prone to noise artifact. And what we are doing now, we are using the existing filter in that machine, which machine we are using, so that it is excluding all the noise artifact.
Thank you, sir.
Okay, any other questions? Dr. Ponapa, from your side, any question?
Good afternoon, sir. Thank you very much, sir. It was a nice presentation, eye-opener. I just wanted to know, for early detection and phenotyping of diabetic peripheral neuropathy, is conventional NCS enough, or do we need AI assistance?
See, sir, diabetic peripheral neuropathy having having a lot of phenotypic feature. Like it may be a sensory neuropathy, pure sensory neuropathy. It may be a sensory motor neuropathy or only motor neuropathy. But common variety is sensory motor neuropathy. Sometimes what happen in NCS, what we are studying is the large peripheral nerves. We are not studying the small nerves which this machine cannot pick up. So in diabetes, the neuropathy starts from the small nerves. So if the patient is complaining, like any patient is complaining, sir, I am having burning sensation of my both feet. You asked, you having diabetes? Yes, I am having 5 years of diabetes. So, and you did the NCV, you may find there is normal test. So how you will explain that normal NCV and patient having so much complaint? So that is the particular thing in the diabetes and few other disease where it only involve the small fiber of a peripheral nerve, but the nerve conduction will only detect the large fiber of the peripheral nerve. So if the nerve conduction is not detecting this result and patient having complaint, we have further test, like we have a QSAT machine, that is quantitative pseudomotor action reflex, or we may do a skin biopsy, that is known as punch skin biopsy, where we can take a small piece of skin from that part where the patient is complaining or any part of the body, There are few particular location we can take, and we can analyze the epidermal nerve fiber density, that is ENFD, so that it will tell whether this patient having a nerve damage or nerve loss or not. Because if you do the nerve conduction study, it will give normal result. If you do peripheral punch cutaneous biopsy and nerve fiber density analysis, you will find significant abnormality in the result. So even so, in your question, so even if the patient having symptoms and nerve conduction is normal, even AI cannot detect that part of nerve damage, what I am telling, and which is the predominant earliest complaint. There is no study at all where only by epidermal nerve fiber density analysis only we can take. What I am telling about, it is the large fiber. I can see the image. It is the large fiber only we can, means current existing machine only can analyze the large fiber, not some small fiber.
Thank you very much, sir. By the way, I am a associate professor of surgery handling a lot of diabetic foots. So that's why I just wanted to some clarification from you. Thank you.
Thank you, sir.
Soumya, yes.
Good afternoon, sir.
Good afternoon.
Sir, I have a question on like every patient does not have the nerve at the same positions. Like may deviate upon the skin tissues. Like it can be little more under the skin or little up on the peripheral part of the skin. So how the sensors are being used to compensate with that depth issue of the nerve, so we can have
No.
the good result in data we are finding.
So you see what it is the technical thing and normal anatomic variation. Like if the patient having a foot swelling, many diabetic patient having a foot swelling, so nerve is very deep. So what we are stimulating, we are giving some current. We are gradually increasing from 10 milliampere, 20, 30, 40 up to 100 milliampere. If you see in the here, uh, here actually, sorry, here current is not mentioned. So there is a current, you are giving a current to stimulate the nerve. So like you are giving to get the correct waveform, that you remember when you are doing the test, we are expecting the graph should be like this, of a median nerve or ulnar nerve like this. If it is not coming, either the nerve is abnormal, either the whatever current you are giving, you are not getting this graph which is the desired result. So that may be abnormal, or you are not stimulating the proper area, that's why you are not getting the desired graph even if the patient don't have the symptom. So if you are getting some anatomical variation, so you have given 20 milliampere current but you are not able to get this graph, you increase the current 30, 40, 50 till the patient tolerate the current, but still you are not getting the graph. That means either the nerve is damaged or you are not stimulating the proper way. So what you will do, you can, the stimulator is there, you can just deeply press the stimulator or just bring slightly this side or that side or front or back, so that it can, there may be small variation. It is not that every time it is same place, but you can manually adjust your stimulation so that you will just look to the graph. If the graph is coming perfectly, that means you are stimulating the same nerve in that same particular location. So by that way only you can tell whether, even if there is variation, you can tell that okay, this nerve is damaged or normal, or you are not stimulating the correct way. So if then you are not stimulating the correct way, you just adjust the stimulator position sideways and stimulate again to get the desired graph. Other thing what you are telling, if it is a deep seated, you will not get the desired graph result. You can write that in the report, the patient having a swelling in the foot, that may interfering the result. So you can correctly correlate the result with your clinical findings, so that a clinician will know, okay, my patient having a leg swelling, that's why they are not getting the result. That is not abnormal. Maybe you will repeat the test after 7 days where the swelling get resolved and you will get correct graph. So in that way you can mention in that report that this is the findings, that's why you are not getting the correct result.
Thank you, sir.
Okay, any other questions? I don't think so. So thank you, sir, and thank you very much.
Thank
And
you.
definitely I'll be in contact you to solve your problems, whatever things you have given in your suggestion box. Thank you, sir. Thank you very much.
Thank you, sir. Namaste.